Okay, we're recording again. So now that we don't have background music, let's see if we can get into it. Okay, so we're going to talk about patients with cerebral vascular accidents. We're going to start with TIAs. I'll get into that in a minute. In your guys' clinical experiences that you have, how many have had patients that have had strokes or TIAs? A fair bit of you. Okay, good. You guys are going to see this, especially as you keep going through your acute care, have some more long-term care rotations. Strokes are really debilitating for our patients, which is why we talk a lot about preventative care and how we're trying to prevent blood clots and we're trying to prevent strokes. A lot of it because it's so impactful for our patients in their lives. So the first thing I want to just mention on is transient ischemic attacks. This is often called TIAs because it's big words, right? It's kind of hard to get your mouth around. But this is temporary impairment of cerebral circulation. It can happen for various reasons. It's not what we call a stroke. Sometimes people in the past would call this a mini stroke. Like it often would have some symptoms of like what you have with a stroke, but it was short-term, temporary, and they usually resolve. So if somebody does have one of these, no, they're 15% more likely like to have it, like those patients will have how do I say that? 15% of stroke patients have a TIA before they have a stroke. It's a pretty big number. So we try to, anytime somebody has a TIA, we get on it as far as prevention, monitoring, teaching education with them, how to look for it. So just know that it's like a mini stroke, but the symptoms are short and they resolve, they get better. All right, so moving on to stroke. I'll put that in backwards. So the pathophysiology, sometimes they call it a cerebral vascular accident. Why do we call, like, let's do word building just for a second, because it helps us understand. What is cerebral? Brain, right? And vascular? Right, your blood vessels. Something's happening where your brain is not getting all the blood and the oxygen and all the nutrients that it needs, which causes damage to that brain. And all the things that we're learning about our brain, all the, all the functions, right? Like it's our computer. It's our computer that tells everything what to do. And when that doesn't get the electricity, well, I'm using blood as electricity, but if this isn't plugged in, this computer, we're not going to see anything happen. And if our brain isn't getting the blood that it needs, we're not going to see a lot of good things happen. It can have permanent damage and have long-term neurological deficits. So there's two types of strokes. Let me just admit here. So ischemic and hemorrhagic. And you guys did homework on this weekend. So you should be pretty familiar. Maybe you did homework last week or the week before. I don't know. I don't assume you just did it over the weekend. But so whenever somebody has a stroke, it's really important to know what kind of stroke they had, because that's going to tell us how to prevent it from happening again, right? Because if somebody had an ischemic stroke, that's usually where there's an embolism or a plaque that goes in, like clogs that blood vessel, right? So thinking back to our homework, what's some of the treatments we use for ischemic strokes? Thrombolytics, anticoagulants, right? Things to break up, like kind of thin the blood, break up clots. We want to kind of promote blood flow. Hemorrhagic stroke, that's where there's bleeding in the brain that causes pressure and damage to the blood vessels. If we don't know what kind of stroke we're having, we assume somebody's having ischemic stroke. If we treat them for that and it's actually hemorrhagic stroke, what are we doing? Right? We're going to make it worse. So it's always so important we know what kind of stroke the patient's having. When somebody's having a stroke, what's the first diagnostic test they usually do? CT scan of the head. That's going to be very indicative, because if there is a blood collection, it's a hemorrhagic stroke, bleeding, they're going to be able to see it. If it's an ischemic stroke, they're gonna have to work that up a little bit more. It's not so obvious, but we wanna rule out, make sure it's not a hemorrhagic stroke, so we know how to treat it. So let's talk a little bit about risk factors. So on the Menti, select all that apply that are modifiable risk factors for the stroke. Okay, so you guys did pretty good. Let's talk through our answers. So age, unfortunately, we can't modify that, right? Because remember, modifiable, non-modifiable. Unfortunately, every day, or fortunately, how you look at it, we're getting a little bit older, and there's nothing we can do to change that age progression. Can't modify it. I'm gonna go to hyperkalemia. Hyperkalemia is not a risk factor for a stroke. It is a risk factor to have some cardiac issues, right? It might cause you to have some arrhythmias, but those arrhythmias, they're not directly related to a stroke. So hyperkalemia is not related really to stroke, so that wouldn't be a modifiable risk factor. And then gender, even though you can change technically your gender, your biological gender, how you were born, that doesn't really affect some of these things with stroke. So it's not we don't call it modifiable. So, but the two things that are modifiable, if you have diabetes, you are more likely to have a stroke. Uncontrolled blood sugar, your A1C is really high, you're at higher risk of having a stroke. Same thing with obesity, you're just higher risk when having a stroke. All right, so the things that are modifiable: hypertension, smoking, diabetes, cardiovascular disease. We say modifiable because there are things we can do. Like, let's say if you have hypertension, we can keep your blood pressure in a healthy range, right? Where you are less likely to have that pressure so high that a blood vessel might burst in your brain and cause bleeding, right? That's something we can modify. There's other things that you might just have genetic high cholesterol that we could try to also, we're going to try to check that. So we're going to modify it. We can't take it away, if that makes sense. AFib, we can keep your AFib under control, right? If we can keep you from getting into AFib. Remember, because AFib, the atrium are just kind of wiggling around, and they're not pumping the blood out as effectively as possible. So that blood in the atrium has more chance to form little clots and be sent out and cause heart attack, stroke, pulmonary embolism.
Chronic stenosis, is that not having a stent, or is that what's that mean?
That's a really good question. I think what they're meaning is trying to prevent it from happening. Like, we can try to prevent carotid stenosis if we can catch things, risk factors early. But you're right, if you already have it, if you've established that you already have carotid stenosis, you might not be able to actually fix or modify that. Sickle cell anemia, right? Patients are more at risk of having strokes with that. Modifiable meaning hopefully we can get that under control, we keep them hydrated, we decrease those risks. And then high cholesterol obesity. Let's go to, so tell me, what are some warning signs of a stroke? Select all that apply. Warning signs of a stroke. All right, let's see. So overall, good job, you guys. Let's talk through it. So let's talk through the incorrect answers first. So sudden dizziness actually is an indicator of a stroke. You might get a little unbalanced with a stroke, but your unbalance isn't usually about dizziness. What is that unbalance usually related to? So it's usually because of muscular hemiplegia or those signals that are being kind of disrupted from the brain. It's not because you feel dizzy, you're not acting or you're not moving things right because you're dizzy. Sudden dyspnea. What is dyspnea? Shortness of air, right? What's sudden severe dyspnea? What's that a sign of?
Like, some lung obstruction or something, you know?
Pulmonary embolism.
Yeah.
Keep that in your brain. Anybody who has sudden severe dyspnea, pulmonary embolism is going to be our first kind of thought. If it's accompanied by crushing chest pain and some other things, then we're also, we're going to look at a heart attack as well, but that's going to be our sign of a PE. Sudden muscle spasticity. That's not really a sign of a stroke. Right, it might be a seizure or something else happening, but not usually stroke. With strokes, we often the sudden severe headache, and we also will see that numbness specifically on one side of the body. Why is it on one side of the body? Yeah, like kind of what you're saying, right? If we have a bleed or a clot that goes up on our right side of our brain, which side of our body is going to be affected? The left, right? It's opposite how that works. So who did I have? I was on call this weekend for the hospital, and I had somebody that had had a stroke. And I asked them, looking at them, they were able to talk, do all these things. They looked really good. But I still always ask my patients with a stroke, do you have any residual effects? Because sometimes they'll just say, you know what, I can do most things, but this hand is just weaker than the other hand. Or I notice that this leg kind of drags a little bit. So you never know what the long-term effects are. Sometimes it's not that this half of the body is totally flaccid. Sometimes it's just weaker or not moving like normal, if that makes sense. Okay, let's move through. So warning signs, confusion, change in vision, trouble walking, severe headache. Your book talks about FAST, F-A-S-T. I added the B on here because that's more current with what we're doing. Somebody who hasn't answered yet today, want to tell me what B FAST stands for? Amar? Facial. Yes, yes, arms. T for time. Yeah, so at this face, right? Look at their face. Is there drooping or anything different? A, what do we do? What do we tell them to do for their arms? Right? If you're out in the community, you say, hey, hold your arms out, or just in hospital, clinic, wherever you're at. Because sometimes if this is the weaker side, it's going to drift down. It's going to do something different. And then S, what is S? Smile or speech, right? Are they sounding differently? Are they slurring, drool coming out, something like that? So the B, anybody else know what the B means? Balance. And E, eyes. Is there difficulty with vision? Is there something, sometimes people will lose, I think your book had kind of a really cool picture, and it kind of showed you how sometimes they just lose like this half, or the upper part or lower part. It can really affect your vision in some funky ways when you have strokes. So big thing with the time, call 911. Why is the time so important with strokes?
Because if it's not ischemic, then we need to get that TPA started.
Yeah, exactly. If it's thrombolytic, we want to get going on that. So the acute signs and symptoms, we kind of talked about that already. Opposite side is affected. I started going down a deep rabbit hole. Is that what you say, of like looking for really good pictures of what you might see? And then I was like, this is just as good as what I found. So I left what your book has on here, but you can see what I'm guessing is happening is she's saying, "Can you smile for me?" And you can see this side of his face just isn't going up as far. With other patients, it's not as noticeable. Sometimes you look at what are these called? The creases here. Is it the buccal folds, I think? Sometimes you'll notice that in one patient, it's like you can see it a little bit here and then not on the other side. It's not as super noticeable. I also ask my patients to stick their tongue out at me just because it's kind of fun. Like, hey, stick your tongue out at me. But really, what might we see when they stick their tongue out?
kind of be drop or, kind of lopsided.
Deviation, right? If there's weakness on one side, if I'm weak on the right side, when I stick my tongue out, it's gonna like deviate over because that's kind of a muscle that's kind of divided right down the middle there. Oh, here, I did put it in. This is kind of some of the visual disturbances that you can have with a stroke. Can you imagine if something happened for you and all of a sudden all you could see was like here down? Like that would just be so wild to me. So diagnostic tests, you guys are absolutely right. A CT is going to be the first radiology study that we're going to have them do. We're also going to do a bunch of other tests as well. Most likely to kind of rule out anything else, right? We want to do an echocardiogram, or we want to look at an echocardiogram. Why? What would an echocardiogram tell us?
The AFib.
AFib. And actually with the echo, that's an ultrasound of your heart. We can actually look to see if there's any blood clots and things hanging out in your atrium, which is helpful. We want to do all these other labs just to see if there's anything else wonky going on. Is something else, we know that hyponatremia, low sodium, can cause confusion. I want to make sure we're not treating them for a stroke when really all they need is some extra salt or sodium to get their sodium levels up. We want to look at their bleeding times. We're going to go over some of the stroke scales a little bit later in class. We're going to get to practice those. And they might do a cerebral angiogram. So remember, what does the gram mean on studies? Contrast. Yep, gram means a contrast dye. So cerebral angiogram, that's looking at the contrast dye through the blood vessels of the brain. That's a really good one to tell you if there's a clot, where did it start at? If there's a bleed, that contrast is going to pull out where that bleed is at. So we're going to do thrombolytic therapy. If they're not breathing as well, right? Depending on where the stroke is located at, it might affect some of your centers of breathing, that control. You want to control hypertension. Sometimes they'll have a fever. Glucose might be off. And then of course, just like anything with the brain, if we're messing with the brain, it could cause seizures as well. So question for you. After an ischemic stroke, thrombolytic therapy has to be given within how many hours? Yeah, all right, good job, you guys. 4.5. So generally, I think the book said 3 to 4.5, which is so funny to me because I'm like, if you have to give it by 4.5, does it matter if it's, anyway, that's a tangent we don't need to talk about. But 4.5, which is why it's so important. When is the start time of this 4.5?
When you start to see something.
Before that, it's their last known normal. Because what about if you're coming in on morning shift and I'm like, morning, can I have breakfast for you? And he's like, move his arm, right? Do I start the clock then? No, because I don't know how long this is going, how long it's been going on. You go to their last known normal. So I go run the night shift before they leave and I say, hey, I need you to come look at him. We come look, and then they say, I was just here an hour ago. We were talking, he was fine. If that's the last interaction somebody has had, then that's when we start the clock. It's the last known normal. Sometimes that clock goes really far back. If somebody's been sleeping all night or they're at home and family comes and finds them and calls 911, we don't know when that last normal. So a lot of people, they're disqualified from having TPA. Most likely it's because it's been really long, but because we don't know how long it's been, which is also why I always do bedside report. Anytime that I'm leaving, taking over, handing off a patient, I'm always like, no, we're both going to put eyes on this person so that we both know what's happening here. Because we want to make sure, right? Don't you want to make sure this patient is the same patient that, if you had them overnight or I had them overnight, I'm giving you, like, we both know where they're at. We both know what their level is. Okay, so the thrombolytic therapy, it dissolves the clot. It can reverse symptoms, but the big thing they talk about is time lost is brain loss. If we're taking up more time, that's more time the brain isn't getting perfused and there's more damage happening. What was I gonna say? Oh, what are some side effects, negative side effects we might see with thrombolytic therapy?
What you were saying earlier, if it's given for the wrong type of stroke, it'll make them bleed more.
So bleeding, yeah.
Bleeding.
So hopefully, even if it's giving for thrombolytic therapy, right? Where I'm hoping we're not ever gonna give it for a hemorrhagic stroke. But what is it doing? It's dissolving clots. It's disrupting our clotting system, how we clot. So we really have to watch these patients for bleeding. Yeah, so we're just gonna be super careful with them. If somebody is getting thrombolytics, they're gonna be in the intensive care unit. They're not gonna be out, you're not gonna do this. You're not gonna be giving this in a clinic or in a long-term care. This is gonna be in acute care in a hospital in an ICU. So post-emergence interventions, I think is so funny. So it's not emergency interventions, it's post-emergent, like after the emergency. The big thing we're gonna do is treat the cause of the stroke and then treat the effects of the stroke, right? So if the cause was a hemorrhagic stroke because their blood pressure was so high, right? That pressure caused weakness in the blood vessel in the brain and caused it just to burst and bleed. Well, we're going to be treating that blood pressure, right? We're going to be making sure before they discharge, we keep them in a healthy range, right? We want to control that so it doesn't cause it again. We're also going to treat the effects of a stroke. If there's damage, we're going to get them involved with all kinds of people to help hopefully regain some of what they lost. To protect from aspiration, what intervention should be carried out first following a stroke? Nice job, you guys. Have a swallowing evaluation done. Anytime something happens with patients where they become more confused, anything like that, we're going to do usually a nursing swallow test where we give them just a little, maybe even a piece of ice to suck on or a tiny little sip of water. And if there is any sign that they might be choking, we're going to go say, hey, you're NPO. We're going to do an official swallow eval. What are some signs of choking? Coughing. If their oxygen goes low, that's something. What about sinus drainage? Sometimes people, especially if they have a diminished gag reflex, you're not going to cough as much. So you're going to see it in other things. Their eyes might water. They might have a lot more sinus drainage. They might have other symptoms, might clear their throat a lot. They don't have that cough, but their body's trying to do other things, which is why the biggest time to do oral care for your patients who are at risk of having who have impaired swallow is before you feed them. But it sounds silly. We're like, brush your teeth after you eat. For these guys, we want to try to rid their mouth of as much because bacteria grows in our mouth. That's normal. It helps to break down the food and whatnot. But before they eat, let's give a nice little clean and rinse out to decrease that bacterial load. Because in case they aspirate, our food is usually generally free of a lot of bacteria and stuff. But if we aspirate a lot of that saliva and spit, it's more likely to cause an infection. So we're just helping to protect them, excuse me. All right, so to prevent a stroke, right? We're going to try to get on the front side of it before anybody has one and say, hey, let's talk about your weight, your hypertension, your cholesterol levels, those things we know that contribute to strokes. We're going to be really helping to educate patients to get those under control. We're also going to talk to them about smoking cessation because smoking, all the problems that it does to your blood vessels and your lungs, it really puts you at higher risk of having a stroke. Sometimes if somebody's at risk of having a stroke, they might put them on some blood thinners just preventatively if they really feel like they're a high risk of a stroke. You might have a carotid endarterectomy, which I say is like a rotor-rooter for your carotid arteries, right? Because if your carotid arteries on each side here, if they get filled up with plaques and such, they might prevent blood flow to the brain. And so they can actually go in and break up all those, that crud, the plaques, and then remove it out. They do that through like it's surgical or through like an intervention. And then if it's carotid stenosis, right? Or if there's other types of stenosis, they'll go in with a balloon and try to open up that stenosed or kind of closed area. So long-term effects, we've talked about most of these. Pseudobulbar effect, anybody remember what that is from the reading?
Like, when they get, don't they act out or something or wanna.
It's labile emotions, right? So they're happy and great one minute, super sad the next, you know? And some of it depends on what part of the brain is affected, right? And so some of these patients can't control these wild feelings and how they're doing. Which speech and language deficit is a patient experiencing who's unable to comprehend all language? So if you can't understand anything, what kind of language deficit are we having? I like different answers. It's always fun. Let's get into it. So receptive aphasia. So first, let's talk about dysphagia from aphasia. What is dysphagia? Yeah, difficulty swallowing. That's what dysphagia is, difficulty swallowing. So there's no such thing as receptive and expressive dysphagia. That's just the dysphagia is difficulty swallowing. But we do have receptive and expressive aphasia. So they're unable to comprehend. Comprehend is to understand. So that would be the receptive. Whatever they're receiving in, they don't understand. The expressive aphasia, that's what they speak out when they express themselves and they talk. They're saying things and either they can't say anything at all, you know, they're complete aphasic, or there's times when the words that are coming out aren't the words they're trying to say. They're trying to tell you that they need to go to the bathroom. Instead, they're saying, my dog fell down the stairs, or you just something where it's just, there's a disconnect with what they're saying. It's very bizarre. So cerebral aneurysm or subarachnoid hemorrhage, we're just going to talk on really briefly. So an aneurysm is a weakness in that artery wall. We talked about it, was it last term with like abdominal aneurysms that you can have? You can have aneurysms in any artery wall, but we're really concerned with it when it's in the brain, right? That's really concerning. You can also have hemorrhages, in different, we're not really talking about subarachnoid hemorrhage, just know a bleed in the brain is bad. Here you can see kind of where this is where angiogram, where they put contrast dye into the brain. And you can see where there's probably like a bleed that's happening here because that's where all the dye is accumulating there, that it's gone there through the blood vessels. So signs and symptoms, you can have, I mean, it's really very similar to like what a stroke would be, right? With the cerebral aneurysm or the brain bleed, sometimes you can also have like nausea, vomiting. Is there on this one? You can have the nuchal rigidity a little bit on this one too, but I would think usually it's the light vomiting, head and disorientation. That's really the biggest signs for these. But same thing, just like we're going to work up a stroke or any other kind of brain thing, one of our first things we're going to do is do a CT, see what's happening. They can do a bunch of interventions. They might do a craniotomy, meaning they just open up the skull, the cranium, and they might clamp off that aneurysm. They might remove it. They can do non-surgical where they can thrombose the aneurysm. I used to work in interventional radiology years ago. And if somebody had an aneurysm like this, it was so interesting because you would get they would have like usually a groin femoral site. They would go in with a little catheter and they'd snake it up through to wherever the aneurysm was at. And then once they found the aneurysm, they do like a angiogram, right? They would put dye so they could see exactly where that bleed was at, where it was pooling at, like that picture. And then they have these little coils and they're like little metal like wires. And then they deploy them, which they go in. And once they deploy them, they curl up. And then they fill up the aneurysm with as many coils as it takes. But if you think of like a little, because they start out straight, but when they deploy them, they curl up together. The blood clots around them, right? All that stuff, it kind of fills up the aneurysm, and then it's, it's clotted off. It's not pushing out anymore. It's very, if the aneurysm, if they're not worried about it like rupturing, they might also just kind of say, hey, let's work on keeping the blood pressure under control. We don't want to make that aneurysm worse by having more pressure kind of building on it. They're going to be monitoring it afterwards. There are complications, with these. They might rebleed. What is hydrocephalus? Swelling and extra CSF usually around the brain. Do we talk about, okay, good. We did talk about ventricular peritoneal shunt. Occasionally, and this is kind of anybody who has excess cerebral spinal fluid. Did you guys talk about this in peds at all? A little bit? Okay, good. So usually you'll see this more with some pediatric population issues. But sometimes who did I just see with one? I think it was a patient. I know it's probably some guy in a grocery store. Because you'll learn as a nurse, you're diagnosing everybody, and I think this was in the grocery store where I'm looking at this guy, but I saw a scar kind of back here, and I could see something under his skin because he's real thin. I could see it snaking down. I'm like, oh, that's a ventral peritoneal shunt. I wonder what you had going on. Because from looking at things, you're like, oh, I know kind of what's happening with you. But what it does, it just allows for the excess cerebral spinal fluid just to be shunted or moved down into the peritoneal area where it's just absorbed and distributed and gotten rid of. So it's one way of getting rid of that extra pressure that's on the brain. This is a picture board where sometimes if somebody is aphasic, it's really nice to have them point to something, right? Like, hey, I need my medicine, or yes or no, or clock, dentures, TV. They'll have like kind of big things that are like a lot of, has anybody worked with these before? Sometimes they're really big, sometimes they're small, but at least it gives you an idea of what they're trying to communicate. When we're doing our assessment for our patients, guys, it's your neuro assessment that you learned in foundations, right? We're going over level of consciousness, vision, pupils, strength, we're going over all of those. I was gonna do group work for I don't think I'm gonna do a different group work. Okay. Give me one moment. Actually, Amanda, can I implore you to help me split up into groups? Well, I pull up what I wanted to go over. Yes, I think so. I just want 9 groups. 8. Oh, not those ones. These. Okay, I think that should give us 9 groups. Should be. All right, so as Amanda is handing out the groups, I just want to go over really quick. So you're going to use a couple different types of scoring for patients if they have neuro deficits. The Glasgow Coma Scale is kind of the standard that everybody uses as an initial kind of like, what's their Glasgow? It doesn't tell us a whole lot about specifics, but it does give us a kind of good indicator of, are they okay or are they real bad? So that's kind of just like a real quick check. So on the Glasgow Coma Scale, and you guys are going to practice this in a minute, so you got to make sure you guys have this in. So the first thing is eye opening. Are their eyes open already? Because that's just spontaneous. If it's to speech, right? And that could be if somebody's nodding off or if they're just kind of altered. If we talk to them and they open their eyes, that's to speech. If it's only to pain, that's and so you score them different levels. So spontaneously is a 4. To speech is 3, to pain is 2. How do we stimulate pain in patients when we're trying to get a response to see if they'll wake up? You can do a sternal rub, which a sternal rub, just so you know, it's not this, we don't go straight to a sternal rub, right? We're gonna say, hey, hey. And then Tara, can I use you an example? I'm not gonna sternal rub you. We'd be like, hey, hey, right? And then be like, hey, hey, hey. We kind of shake them a little bit. Sternal rub, I want you guys to get your knuckles out. So have this kind of line of knuckles. I want you to put it on your sternum, and I want you to push till it hurts. Right, it doesn't really, it does not feel good. It does not feel good. If you don't want to do a sternal rub, you can also pinch their nail beds, right? So take your hand, I want you to pinch your nail bed really hard. Sometimes we can't get it too hard, so sometimes they'll use a hemostat and really clamp down on it, which sounds kind of cruel, but what are we trying to determine here?
Sensation.
Not even sensation. We're just trying to say, will they wake up? Do they wake up? Because sometimes people won't wake up to, hey, hey, we're kind of shaking them, but they'll wake up to pain. Exactly. We need one more. I'll wait till we get into groups to see if there was one missing. Sorry. Melanie, it's TBD. All right. So then motor response. Do they obey commands? If I say raise your arms, they raise their arms. You know, that's easy. If they move to localized pain, I'm sorry, Tara, you're just right here. If I go and I'm like doing my, like trying to pinch your fingernail and you pull away, yeah, that's moving away from that pain. If it's, or excuse me, if it's move to localized pain is if they're grabbing their belly because it hurts. Or they're like, oh, you know, they're doing, something seems to be hurt. And then flexing away from pain is, that's when I'm doing, like I'm applying painful stimuli. Abnormal flexion, what's abnormal flexion?
We talked about the Kernigs and the.
Not the Kernigs, but yeah, corticoid or, not corticoid,
Decorted or
yeah, corticoid and decorticoid, thank you. Or if they're abnormally extending, right, flexing or extending, and then one is no response at all. So you can see where the higher the number, the more normal they are, the lower, the worse they are. It doesn't give us a lot of specifics, but it really kind of lets us know good or bad, somewhere in the middle. The other thing that I'm going to have you guys do is the NIH stroke scale. And sorry, I didn't have one pulled up because didn't. And so sometimes if you work on, depending on where you work, they're going to have you go over, you might get like trained on this. So this isn't a big training. This is going to give you overview to know how to generally do it. So the first thing, you're going to ask them some questions. I'm just going to say, ask them the name and date for right now. We're not going to get into what to ask. So when you practice, what's the name, what's the date? If they answer both correctly, that's 0. The NIH scale is opposite of the Glasgow. NIH lower score is actually better, right? The higher the score, the more severe you are, the more worried we are. So then we go to commands. I want you tell them to do 2 different commands, right? Like maybe close your eyes and lift up your hand, or you know, something else. You just give them 2 commands. The gaze, normal, like looking around, have them finger track, you know, is one eye kind of drifting, one eye is not following, but the other eye is, or maybe both eyes are not following. Visual fields. How do we test for visual fields? You actually go, let me know when you can see this. And you go down here, or here, or here, or here, or here. And then you do it at different intervals because patients are, you know, everybody wants to do good on a test. So they might say, yes, yes, because they want to be able to see it, but you kind of will wait or do things quicker to try to make sure you're getting a true result. Motor. So we talk about drift. That's when you have them hold both hands out. And it's got right and left, so you can see there's the left arm and right arm. So you have them hold it out for at least 10 seconds, right? Because sometimes the neurodeficit isn't so bad. They can put their hand out, but after 10 seconds, one might start to drift, right? So that's what we're looking, is there drift after 10 seconds? Or does it fall before 10 seconds? Or is there no effort against gravity? Meaning, if they're laying in bed and they can kind of move their arm side to side because it's supported by the bed, that's no effort against gravity. But if we hold up their arm and it just drops down, that's where there's no movement. They can't even move against gravity. Then the same thing we do with left leg motor, right leg motor. Now, I don't have people do both legs up at the same time because that takes a lot of core strength that might not tell us truly their, what's going on, but just one leg at a time and then the other leg at a time. Then we go into sensory. Can they feel things? And with sensory, it's just abnormal or normal. And you just do like little touch their legs. Can you tell me when, and I don't say, can you feel this? I say, tell me when you can feel this. Because sometimes people, especially with strokes, if they're having some aphasia, all they might be saying is yes. They might say yes or no to everything. So I say, tell me when you can feel this. And just like with the little visual fields test, I'm going to alter it. I might not touch their leg right away. I might wait a little bit or touch a couple different places and let them tell me when they can feel it. Neglect is one, language. So mild aphasia, is there just a little bit of slurring, a little bit of something seems off, or does it get more severe, or can they not speak or they're totally aphasic? Neglect is a little bit tough. I'm not going to have you guys really worry about it too much. With neglect, sometimes you'll see somebody, and what it means is they're neglecting usually part of their body. Like if they have hemiparesis, sometimes they'll say, I can't move my left arm. With neglect, it's like they forget that they even have a left arm. They're like, for something in their brain, it's like they don't even know that it's there. Like they just don't even feel it, see it, process it. It's kind of tough. That one's probably the most tough in my opinion to assess. So we don't have to get into that right now. So those are the ways to score. What I'm going to have you guys do is hopefully we have groups of 4 and I have 4 scenarios. So you each are going to get a chance to act out one of these things, to be a patient. And then I have scoring sheets so that your group members are going to collaboratively fill out a Glasgow coma scale and an NIH coma scale based on how you're doing. We're going to get together at the beginning of every group or every scenario. So you guys all kind of know how to act. I have cheat sheets for you to remind you. And then we'll get together and say, hey, how did we score these people? And then we'll break up for each of the 4 scenarios. Kind of makes sense? Yeah. Okay. Let's go ahead and get into your groups and then we'll go over our scenarios. All right. We're now recording again. So go ahead and join me on the Menti. Once you join, go ahead. I think maybe only I gave a thumbs up. So go ahead and give a thumbs up when you join. Thank you. So last week, we talked about the central nervous system disorders. What are some of the things we talked about last week? Meningitis, encephalitis, spinal injury, head injury, headaches. Yeah, all those things. So kind of the central nervous system. This week, we talked about strokes, and we're also going to talk about the peripheral nervous system dysfunction. And what? And a new Menti, yeah. New Menti, so you can join up here, or the code is on the board as well if you get kicked out. Before I start with this, so I'm gonna give you guys just another moment to join up. Well, let's go. All right. Oh, I get right into it. Okay, so the way that I've kind of broken this up is through different diseases. I thought about trying to pull another Venn diagram, but I don't really have one that kind of is enough for all of these. But when you're taking notes and writing down things, if you have a way of highlighting or marking,
what are some of the ways that these diseases are similar? And what are some of the ways they're different? Because some of these things we're gonna talk about are very similar, but they have some differences. And so those are the things I want you guys to kind of focus on. So multiple sclerosis. Also, a lot of times it's abbreviated to MS, or it's called MS as a disease. So first off the bat, the question for you. Symptoms of multiple sclerosis are caused by damage to what structure or structures? Sorry, Jamie. You're getting your squats in today. So yes, you're right. The myelin sheath. So do I have a picture? Yeah, so here's a picture of normal myelin sheath coming off of on the nerve. And then we have where some of the sheath here begins to break down a little bit. So here, see how it's nice and smooth on the edges? And in the middle, there starts to be little like cracks, almost it looks like on the sheath. And then down here, you have where it's cracked apart, even like totally separated in some areas. And so you can see how this could really impact nerve conduction on these patients. So you get where the degeneration or breakdown of that myelin sheath, your nerves get very inflamed. And so their nerve impulses that are being sent out are slower, delayed, and sometimes totally even blocked. We don't know what causes MS, but we think there could be an autoimmune component to it. Maybe viral infection. There could be some hereditary portions to it as well, but we really don't know why some people develop it over other people. Signs and symptoms are going to be muscle weakness, numbness, fatigue. Sometimes you can have slurred speech. If you think about anything like bowel and bladder, mood alterations, anything that you're sending a nerve impulse is going to be slower or disruptive. So how you walk, how you talk, swallow, all those general things, like anything you're doing right now, you're writing, you're breathing, everything's going to get slowed down. So there's 3 types of MS. And this is it's important to know if your patients have MS, you want to know what kind they have. So the first type we're talking about is relapsing, remitting, or RRMS. That's where somebody might have a relapse, meaning they start having a lot of weakness, a lot of maybe trouble swallowing those issues, but then they get better. So it's a relapse that resolves. They get back to baseline. The next kind is secondary progressive. So meaning it's kind of like the relapse readmitting where they start to have weakness or other issues, but they get better, but maybe not all the way back to baseline before they have another relapse where they start to get worse. The third kind is primary progressive, and that's where they don't have any kind of resolution, where sometimes, it gets worse and it gets better. These guys, it just is a continual slow decline. Why people have different types, we don't know. But it's important to know if your patient, if they have a relapsing readmitting, to know where they're at in that, if they're back to baseline, or if they're primary progressive, we know this is as good as it's going to get for them, right? We're not trying to get them back up to another level. We're trying just to kind of slow progression and keep them safe the best that we can. So it's important to know what kind of MS the patients have. Some other things you might notice, exacerbations. So this isn't necessarily a relapse, but sometimes if there's a lot of stress happening, kind of like we talked about endocrine last term, how stress can really affect your body, you might have an exacerbation of symptoms. That's not necessarily a relapse per se. If we can get those symptoms under control, or that stress or whatever's causing it under control, hopefully we can get back to, that level of functioning before. Some diagnostic tests. How do we diagnose it? Well, history and physical, they're going to rule out some other things by getting spinal fluid testing and MRI. And how do we treat it? So steroids won't help with inflammation, right? Those nerves get really inflamed. Sometimes they might give some medicine to
decrease, if they think it's immune system response, they're gonna give some medicine to hopefully suppress your immune system, so it won't attack those nerves the same. If it's causing issues, like if you're getting really tense muscles or spasms from some of these nerve conduction issues, they might give you medication that might help with that. They also can do plasmapheresis, and that's where they hook patients up, kind of like dialysis, but to pull off some of the plasma. The hope is that if this is an immune component, some of those immune cells that are attacking the nerves will be pulled off in that process. So it will decrease how many of that, I mean, your body's going to build it up again. If it's an immune response, they're going to build it up again, but it will be slower. All right, so now moving to myasthenia gravis. The book called it MG. I never in the industry have really seen it abbreviated MG, but maybe you'll see it in FA Davis as well. So with myasthenia gravis, this is where you have antibodies that your body produces that destroy acetylcholine receptors. And so acetylcholine is what we need to stimulate muscle contraction. And so if we have antibodies that are stopping that production, we really have a hard time moving, contracting our muscles. I think, okay, good. So here we have like neuron and motor junction here, and you just have where these receptors, which are these little pink things, they just get kind of destroyed, where even though you might have ACH, but the receptors are not working as well. So we don't know exactly, again, a lot of these diseases are very similar in that we don't always know what causes them, what's caused the body to form these antibodies. But we think it might be autoimmune. There's a little bit of correlation with people who have a thymus disorder. And there might be some viral issues. A lot of these, kind of like with diabetes, you know, we learned about type 1 diabetes. There's usually a virus or something that kind of just sets the immune system off to then start developing this disorder. Similar for some of these other disorders where a viral infection will kind of like kickstart the immune system to then have this disease that they were, you know, people have. So it's progressive muscle weakness, right? So if you think about those ACH receptors are blocked, the muscles are progressively getting worse. The big kind of sign for me, and I highlighted it for you because this is how I like to, how it helps me to remember, is that they have fatigue with activity, but it gets better when they rest, right? So somebody with multiple sclerosis, they're going to have weakness and stuff maybe all throughout activity, rest, all of that. But with myasthenia gravis, that's really going to help them to rest. They are able to kind of rebound from that. They also, anything you have with muscle activity, walking, chewing, breathing, all of those things are going to be affected by it. And stress, there's going to cause exacerbations, just like with multiple sclerosis. So what are symptoms of a cholinergic crisis? Select all that apply. Think about cholinergic. I like it when we get varied responses. And I like the color scheme. I think it fits our baby theme today, like with the pinks and I guess there's blue and purple, but it's like baby colors. All right, so let's get into this. So it's everything that's coming out. Whatever you're excreting, it's more. So you're not constipated, it's more like diarrhea. You would have more urination, vomiting, you guys know what lacrimation?
Tears.
Yeah, tears, just tears coming out. Not necessarily spasticity and headache. So the biggest complication with myasthenia gravis is that you have complications for muscles that cause, that are associated with breathing and swallowing. So, because remember, this is a general progressive disease. It's not like MS that maybe has remissions and like getting better and getting worse. It's just going to continually get worse. And the biggest issue for these patients, not necessarily just it's weakened when they're walking, it's they're swallowing, going to aspirate something, and they're not going to be breathing as well. So they're probably, with that aspiration, going to have more issues or just have pneumonia in general. You can also have these cholinergic crisis with these guys. Sludge, is it on here? Oh, it wasn't on here. That was their way of remembering it. Essentially, I think the book said something kind of like what I said. It's like something's coming out of every orifice. You're excreting out of every orifice is the cholinergic crisis. So diagnostic test, this one, they're going to also test you for these ATH or anticholinergic receptor antibodies, because that's going to actually tell them if this is myasthenia gravis, right? Because if you don't have those antibodies, it's not myasthenia gravis because it's not breaking down those antibodies or breaking down those receptors, excuse me. So what do we do for it? Well, if it is related to the thymus, right? Some of them, we think they're related to the thymus, we might go ahead and take it out. They might have some anticholinesterase agents just to help boost the ACH that's there. Steroids, and again, plasmapheresis might be helpful to just get rid of, kind of pull out some of those antibodies that are in their system. So which nursing intervention is the most important for a patient with myasthenia gravis? Or gravis? I'm not sure exactly which way. I think you can say it either. All right, so good job, you guys. Allow for frequent rest periods, right? Because we're going to give them some time to rest so that they can kind of regroup, right? Because they're expending all of that ACH, the acetylcholine, right? Because the acetylcholine is what helps to move muscles. So if they're spending it all out, we're going to be so tired. So that's why we need to let them rest and then get a little bit better so that they can do the next thing. So nursing activity and tolerance is a big thing. We talk about conserving energy. Sometimes it's little things, how do we help them look through their day about what's necessary, what's not, what can you ask for help, what kind of assistive devices might you need? Also support groups. Actually, for any of these guys, support groups are really helpful to have other people who maybe are going through the same things that you're going through, who understand. That's going to be very impactful for patients. So the assistive personnel reports that her new patient with myasthenia gravis is too fatigued to take a shower this evening. What do you do? Turn to your partner and kind of talk for a second. What would you do with this patient? All right, let's compare to see your guys' answers with FADs, right? So change them to a morning bath is one option, or don't make them take a bath or shower, right? Because we know if he's too fatigued already, that activity is just going to make everything worse, right? So we're not going to push that because that's going to end up in a fall or him getting hurt, we're getting hurt. And then let's check on the patient. If he's feeling more fatigued tonight, if he's too fatigued to shower, we just need to look at him and make sure there's nothing going on with him, right? Because if he's getting sick, something else happening, he might kind of be amping up, or he might be having an exacerbation. We want to keep track of that. Also, they have more energy in the morning, right? We've been rested. So the things that we want to do with these patients, they have doctor's appointments, activities, therapies, we probably want to do them earlier in the day because they're going to have the most energy to be able to do those things earlier in the day. All right. ALS or amyotrophic lateral sclerosis. It's a really hard one. In the industry, everybody says ALS because it's a long, hard one to say. It's also called Lou Gehrig's disease. I don't know who this was. I had to ask my husband because I was like, remind me who's this person? He was a baseball player who apparently, my husband said he was the GOAT, I think. He played like hundreds of games like consecutively, like for a really long time. Anybody know baseball? Am I saying the right things? Okay, here I see some nods. Anyway, apparently he was this really good baseball player, amazing, very physical, strong, worked really hard, but then developed this disease. He wasn't able to continue like he was before because he was such a popular sports figure. A popular sports player. I do know about some sports, just not baseball. And so a lot of people, it brought light on this disease because just like anytime a public figure gets a disease, it's in the media, people know more about it. So your motor neurons degenerate. Those nerve impulses, because of that, they just get blocked where you can't transmit your nerve impulses. And then you get weakness and your muscles atrophy because they're not able to, get stronger, similar to the other diseases we've been talking about. It's unknown what causes this. There might be some genetic predisposition. We see it sometimes in family lines, but not necessarily. Some of the biggest signs and symptoms is you have progressive weakness and atrophy. So with these guys, they also have this muscle spasming and twitching. We don't really see that in the other diseases that we've talked about. We do see general weakness, but not that spasming and twitching with that delayed kind of muscle response. Again, they have difficulty chewing and swallowing. These are trends with all of these diseases. Anytime our muscles are being affected, these are muscles that have to be very well coordinated to work. We also see some emotional lability here, kind of swinging of emotions. And then oftentimes people with ALS will die from pulmonary complications because the muscles that control respirations, or maybe they've aspirated, those will continue to get weak and that will cause issue. So they diagnose it, history and physical, like all these other ones, really nerve biopsy. That's going to be able to tell them a lot more about what's going on specifically with the nerve to diagnose ALS. Therapeutic interventions, it's kind of symptom treatment, right? We can't really reverse it, but they might give some muscle relaxants or things to help with the spasticity or spasms. Want to do all of these guys, we're probably going to have them in speech and occupational therapy to try to regain strength, help them learn how to move. These guys have pretty severe progressive speech loss. And so sometimes we do augmentative alternative communication, Stephen Hawkins. Yeah, exactly, right? So Stephen Hawkins is a great example of somebody who had the augmented communication to be able to talk. There's a lot of computer things, ways for people to be able to communicate with other people because the brain, as far as the thought processes are there, the ability to communicate is not. Which has to be very scary for these patients. We really want to teach these guys importance, all of them, about avoiding infection, because we know infection is going to increase exacerbations and continue on that disease. And then with this one, it's so degenerative, we want to make sure we're involving family with care. The other conditions, we want family to be involved with care. As it progresses, it gets worse as well. But ALS, it's pretty quickly degenerating. So activity cue, a patient with ALS reports that he's starting to cough and sneeze during his meals. What do you do? Go ahead and turn to your partners. Just real quick, what do we think is happening? What do we do? All right, let's compare your answers with F.A. Davis. So the first thing we're going to do is safety. We're going to make him NPO, right? We don't want to feed him because we know that this might be aspiration, right? Not everybody coughs. You might just have sneezing, runny nose, watery eyes. So we're going to notify the healthcare provider. We say, I have a concern, right? I'm uncomfortable feeding him. I have a safety issue, right? That cuss that we use. And then we're gonna, and just to remind everybody, when we do the cuss thing, concerned, uncomfortable, safety, you don't have to say all of those. Usually just one of those words will work. But we want to probably say, hey, if I was going to go through SBAR, my recommendation at the end would be, I recommend that we have speech therapy consult to do a speech swallow or do a swallowing assessment to see if he's safe. And go from there. We know about that. Okay. Anybody speak French in the room? Nobody's willing to admit it. Okay. Ah, I say Guillain-Barré. Yeah, okay. I don't speak French very well, but it is a French, like it's after a French, I think, physician. And so Guillain-Barré is how you say this. Ish, if you're close, people will know. But it does look like Guillain-Barré. So just know, if you say Guillain-Barré, right, I mean, as new nurses, you're gonna say things wrong. It happens. The biggest thing I want to encourage you to do, be welcoming when other people say things wrong, right? Because if we can make an environment where, hey, it's not that I just want to know that you know what you're doing, we're doing the right thing for our patients. If you say the word incorrectly, we can figure that out, Okay, so Guillain-Barré. So this one, it's inflammation of the spinal and cranial nerves. Hey, that already tells me that's a little bit different from some of the other ones we're talking about, has kind of general or kind of global bodily effects. So there's segmental demyelation in an ascending pattern. Oh, that's a lot of big words, okay? So segmental, right? Segments. Demyelination. What is demyelination? Yeah, essentially deteriorating or like destruction of that myelin sheath in an ascending pattern. What's ascending? Yeah, going up. So if we're getting destruction of the myelin sheath, what's going to be the symptoms? Yeah, those nerve conductions are going to be slowed down or even lost. So you're going to have weakness or inability to move certain muscles. And with Guillain-Barré specifically, it starts in the periphery, farthest away, so usually toes, and it moves up. So with Guillain-Barré, oh, you also have descending remyelination. And there's phases on here we'll talk about, but you essentially, these patients will have it. It's an inflammation of nerves, and it will start with numbness, and it will generally go ascending. Now, think about when we talked about spinal cord injuries last week. When it gets to a certain point up in here, what's going to start happening? Diaphragm is our biggest one. Our heart's it's got that automaticity thing, so it's going to keep beating usually regardless, but our diaphragm's going to be involved. And as it ascends, oftentimes people aren't able to move at all. But then what you also have is once it's plateaued, people usually then recover and it descends the remyelination. So then it starts to go back where they can start moving again, breathing again, bowel and bladder control, they can move their legs. Very scary. During that time when it's, gone above the diaphragm level, oftentimes these patients have to be put on ventilator support or other things to help breathe for them until they can get to that remyelination phase where they're the myelins are getting kind of reformed and recovered. They can, yeah. Who was it I was just talking to? Oh, I can't remember, but they were saying that their spouse had myasthenia gravis and he was doing great, so they can fully recover. But it's. I had a patient in rehab that had that syndrome. Yeah, what did they look like? He left AMA. What was she in the descending phases? Yeah, I think lower. Okay, so she was still, and it can take a very long time for that descending remyelination to happen and have full recovery. Oh, Amy. Okay, we don't know what causes it. Huh, that seems familiar. Could be a response to a virus. Also familiar, right? Signs and symptoms. So here's the stages. So with Guillain-Barré, you have the stage 1, and it can be 24 hours to 3 weeks. So very rapid or pretty slow, where you have this abrupt onset where it just slowly, you become weak and even paralyzed going up. Then you have this plateau stage, or it's stage 2. And that can be anywhere from 2 days to 2 weeks, where whatever level it stops at, but often it goes all the way. You're kind of there and you're hanging out. So as you're there, we're supporting you. We're helping you breathe if you need it. We're doing what we need to do to help. Then you have stage 3, which can be 6 to 12 months. And that's the recovery or remyelination that you gradually get back all of those things. So who knows, maybe somebody will come, we'll see your patient in 6 months and she'll be walking around. She'll be walking out AMA instead of wheeling out AMA. So which assessment takes priority for the patient with the Guillain-Barré syndrome? Yeah, nice job. Respiratory rate and breath and depth, right? We want to see, make sure that diaphragm hasn't been too affected by that demyelination. Complication, respiratory failure, infection, pneumonia. These guys can get depressed, right? Because it can go like right in the course of 24 hours, you could have complete demyelination and be in the ICU on a ventilator, and then have up to a year of trying to get back your function and sensation. It's very tough on patients. Diagnostic tests, you know, we're gonna do some of these lumbar puncture, look at the CSF. We're gonna look at EMG and nerve conduction, because we want to really see those brain nerves or the cranial nerves, because that's really kind of part of what's happening as well. Well, not really. We're gonna look to see what's caused that breakdown though. So again, we might do plasmapheresis on these guys. That might help kind of pull some of those attacking things in their blood. Oxygen, ventilation, rehab, we talked about that. So nursing care, really a lot of it is supportive, right? It's kind of like, are they breathing okay? Is there anything else we need to do to keep them safe, right? If these guys are totally immobile for several weeks, we know they're higher risk of pneumonia, they're higher risk of blood clots, they're higher risk of skin breakdown. So we're going to be doing a lot of things to help promote their safety and health while they're in that stage. Okay, moving on. Post-polio syndrome. We don't see this hardly ever. Is anybody taking care of somebody with polio who's had polio? Yeah, it used to be a lot more common. More so, I've been a nurse for 24 years now. I was a CNA before that. And I used to 20 years ago see not a lot, but it'd be fairly common to be, oh, this is somebody like you'd be with a cane really weak. And I would be like, okay, what's happening here? Well, they had polio, right? Why don't we see polio anymore? Right? We have vaccines for it. So most people don't have polio anymore that we see. But there is this thing called post-polio syndrome that just a quick one I want you guys to be aware of. So usually it's 10 to 40 years after they've had polio. So they might still have some residual effects from the polio, but 10 to 40 years, all of a sudden they get muscle weakness, pain, fatigue, respiratory compromise. We don't really know why it happens, but it's like all of a sudden something with that polio virus kind of does something in their body decades later. So what we do, well, we just support whatever's going on. If they're weak, we get rest, we provide some physical therapy, help to get some strength back. If they're having trouble breathing as part of it, you know, we're going to support their breathing however we need to. It's pretty much it. Like that's all I really want you to know is that after you've had polio, 10 to 40 years, you might have kind of this little relapse of it. Similar. It can reactivate in different ways. And so you just have to be aware. So if somebody comes in with these neuro deficits and they have a history of having polio, that's something we're going to be considering. All right, restless leg syndrome, new one. We're moving on through all of these. So this is where you have a dopamine and serotonin imbalance in your body. Why it's caused from lots of different things. I actually had restless leg syndrome for a summer. Because I know it was a short-term thing. But for me, I started noticing when I was in longer car rides, my legs would just like I just had to move them around. Or at night when I'd be resting, they needed to move. Like what? And so I diagnosed myself with restless leg syndrome. But then I was trying to figure out, okay, what's caused this? And I couldn't figure it out. But then I did some deep diving and I was like, oh, anemia, iron deficiency, that can cause it. So give you a little more history. I'm perimenopausal, and when you're perimenopausal, sometimes your menstrual cycles can change. Mine changed to be very, very heavy. And so I went from 1 year being totally fine. I had my labs drawn with my doctor and I was great. And the next year I was extremely anemic. My ferritin level, I think, was less than 3, which is supposed to be, I think, at least 20, I believe. Anyway, I went to my doctor and she was like, what is happening with you? And then I thought back, oh, I've been eating ice chips all summer. Which, do you remember, what is that a sign of? Iron deficiency, right? I actually cracked a tooth from eating so much ice, which goes to show you, just to have, even though you have the knowledge, you don't always apply it to yourselves. Anyway, I called my doctor and I was like, listen, I just want to get my iron drawn. And she was like, what are you talking about? And she was like, you need to come in to see me. And I was like, I don't think so, but okay. Anyway, it ends up that I just was really iron deficient. And now that I'm on my iron supplement, I feel better. I did run out of it 6 months ago, and I forgot to refill my iron supplement. And guess what happened? I started noticing like after a couple of weeks, my legs were like, I was like, oh, I got to get that supplement again. So it really can affect that. Fortunately, mine was pretty mild. Some people can have very debilitating effects of this restless leg syndrome when anytime they stop or don't move, they just feel twitchy. It's uncomfortable. It's like spiders or tingling in their legs, or it's really uncomfortable. Yeah, men or women. Mine was because of iron deficiency, because of perimenopause, but men have it all the time too. So mine was from like iron deficiency, but things like kidney failure, diabetes, Parkinson's, they could all contribute to it. So it's various reasons that it can happen. Mine just was from no iron in my body. Signs and symptoms. So you're crimpy, crawly, pins and needles. A lot of times people can get very fatigued, like their legs are just, and not general, but just their legs feel really tired. Sometimes they say the legs feel heavy. It can also keep them awake at night. When I was back home visiting my dad, he has restless leg syndrome. I had to keep buying him more sheets every couple of months because the foot of his bed on the sheets, he like rubs holes in them. I was like, Dad, I just bought you new sheets. And then I'm like, well, they're big, but he just like rubs. So they can be pretty bad. So how do we diagnose it? Well, if they symptomatically, we can usually say, oh, this is probably what it is. They also, like I said, test for iron deficiency and also look at medications because sometimes that can contribute to similar signs of restless leg syndrome. So interventions, we kind of want to intervene with whatever's causing it. Like with mine, I took an iron supplement, I felt better. Sometimes with patients, they can do some medications that can help control the symptoms of this. But we also know that things like smoking and alcohol can also irritate it. An exercise routine can be helpful. So maybe not exercising, running 50 miles one day. Okay, nobody runs 50 miles. Running 5 miles one day and then not doing it for a week, but kind of keeping a routine exercise schedule can help kind of diminish some of the effects. Okay. Changing again. So cranial nerve disorders. We're going to talk a little bit about trigeminal neuropathy and Bell's palsy. So trigeminal neuropathy, anybody want to point to where their trigeminal nerve is at? Yeah, kind of back here on the face. Yeah, back through here. So the trigeminal neuropathy, it's irritation of that trigeminal nerve. It kind of starts back here and kind of fans out over the face on both sides. It's irritation, or sometimes it can be compression of some sort, something that's kind of pushing in there of that trigeminal nerve. And so the signs and symptoms, oh good, I put a picture. So yeah, see how it starts kind of by the ear and it kind of like, it kind of just like goes all through the face. So you have intense pain, and it's usually just on one side of the face, right? Because if you're having irritation of this nerve, it's not necessarily both sides. It's usually something that's causing irritation to that nerve. So it's usually just one side of the face. And usually it does go up through the forehead, through the cheek, down through the jaw. It really gets triggered by touching it, talking, other stimulation like chewing. Yeah, exactly. Anything with your face, it can get really irritating, very painful. So you want to do it history and physical. You want to do a CT scan, see if there's something growing that's kind of maybe pushing on that nerve, maybe an MRI. And then to help, we might do some anticonvulsants, some medications to help kind of like calm that nerve down, right? The medicines that will help calm the nerves down. They might do a nerve block, meaning they might inject some lidocaine around that nerve to kind of numb it a little bit, help numb some of that pain. And then sometimes they can even do surgery to try to cut or block those pain, the nerve conduction permanently. Okay, Bell's palsy. So this one, it's different because I always think trigeminal neuralgia, it's one side. Bell's palsy in one side, but painful. Bell's palsy is more of a paralysis of one side of the face, but not from a stroke. You get inflammation or swelling or edema of this of facial nerves, and you just lose control. So yeah, here's one picture of it. So you have somebody who has just on one side, you can have some pain, but generally we see like where it's just. So this is the, they're telling him to close his eyes and smile. So here, he's not closing his eyes, he's not smiling, he's not doing all those things that we're asking him to do. So we want to rule out a stroke, right? Anytime when somebody has total facial paralysis or weakness, we're like, oh, we usually think stroke. Then we want to probably do some electrical studies of the nerves and see what's happening. Are they getting connected? Yeah.
This or Bell's palsy put you at a higher risk for possibly developing a stroke? No.
No, because it's just nerve conduction that's being impaired. It's not anything in the vascular part of the brain. Yeah, but good question. What's that? Yes, it can go back normal. Once you can reduce the swelling or inflammation of that nerve, then it can go back to normal. What's that?
Justin Bieber done.
Oh, did he get
You
this?
can get it
Oh.
from dental work too, if they need the nerve.
If they irritate that nerve, yeah, and so you can go totally back to normal. So if you guys can hear, Justin Bieber had this. So just like with any famous person who gets something, it's a way to like remember or relate. So we might give some prednisone. Why do we give steroids? Yeah, for the inflammation, right? It'll help with the inflammation. Might give pain medicine. Gentle massage and moist heat can be helpful for this. Would gentle massage be helpful for trigeminal neuralgia? No, right? Because touching movement is actually increasing the pain with trigeminal neuralgia. So we wouldn't want to do that. But this one, gentle massage might help. All right, the patient with which disorder would benefit from avoiding cold, windy weather? ALS, Bell's palsy, trigeminal neuralgia, or MS? All right, trigeminal neuralgia, because touching irritates it. You have cold wind that's blowing on that side of your face. That's a nerve that's caused or having the issue. That can be very painful for patients with trigeminal neuralgia. Hey, we're done. Okay. Let's do Jeopardy. Okay. So I have another idea. So are you guys in your groups again? Do we separate? Okay, get back into your groups, please. Yeah, back to the group you had before. Hold on. Okay, over here.
We're playing a game.
Do you guys?
No, we actually were just talking, I think it's Amanda. Some alternate dates, because we were.
So go back to whatever.
Your neuro assessment. Very limited words. And then so that's what we're talking about. Alternative dates. Vote for whatever one works best, or say neither, if neither is an option. Or just trying to take the time. And I think it depends on how. Is the number on there?
Okay, so I thought about it. To be a little more fair, we're gonna rotate. So whoever has the number, you can start, maybe Bree will start, be the, like, for the first question. And then the second question, it would move to Kara, and so on. So everybody's gonna have to, like, every question, you'll be switching through being the answer person.
Yeah, because I'll just win again, guys.
Some people are more comfortable raising and lowering, so we're just gonna we're kind of spread it through. So decide who's gonna be your first question raiser answerer. One, two, three, four.
Against her, I would when I have.
I can't do this fast.
It's still early for me.
Okay, I figured out how to make my own Jeopardy instead of kind of hacking another one, so I am very excited. I'm gonna name you guys just like clockwise. 1, 2, 3, 4, 5. Wait, is it all? 1, 2, 3. Oh, 4, 5, 6, 7, 8. We'll be able to remember that. Okay, so as practice, who's got the cards? And if I would say ask a question or ask a question, you knew the answer, you would do what? You would raise them up. Okay, perfect. Okay, so you guys over here. Luck of the draw, you get to choose the question first. So I did put them into categories of just like what we just talked about. MS, myasthenia gravis, ALS, Guillain-Barré. And then potpourri, if you guys know Jeopardy, it's just kind of whatever. Anything. Okay, ALS 200. So if you're the guesser, have your guesser ready. ALS 200. And hold it really high because I don't have Amanda to help me see. ALS 200. The cause of this disease is oh, there we go. Unknown. Yes. Sorry, I couldn't hit the right button. Yes, unknown. Okay, you guys are 1, 2, 3, 4. Okay, so we're switching. If you were the one who held up before, we're switching. All right, so you guys, group 4, which one are we going with next? Oh, let me escape.
MS for 200.
Myasthenia gravis for 200. Most complications are due to what?
They said
In the-
MS. It's.
Oh, did I do the wrong one? Oh, sorry. Well, yeah, it's still you. Yeah, still myasthenia gravis. Yeah. Whoa. Good job. That was perfect.
That was exactly
I did pull these answers from the book, which is what the PowerPoint is from. So if you have your book right there and you can answer it, that's good. Okay, so you guys are number 5. So sorry I didn't choose the right question earlier. All right, so what question? So switch guessers. And what number are we gonna go with? MS 500? Woo, okay, get your guesser ready. May be used to remove antibodies from the blood that are attacking the myelin. Rachel? Plasmapheresis, yes, with a little delay. All right, which one are we going with now? Oh, wait, actually, switch your guessers. Again, all right, switch your guessers. Okay, MS, multiple sclerosis for 300. MS is categorized based on this. It's how the disease progresses. Yes, yeah. How many types are there of MS? Yeah, there's 3 different types. Okay, switch your guessers. Oh, wait, you guys are 7. Thank you. All right, and who's gonna choose this time? You're choosing?
Oh. We're gonna go with potpourri for 300.
Ooh, potpourri for 300. It could be anything. This disorder is characterized by paralysis of one side of the face. I saw Kathy.
It is, Bell's palsy.
Good job, Bell's palsy. If you raise them really high, like that helps me. If you just raise them a little bit, I can't see it. So you gotta go high. I can't read and see. We're testing my peripheral vision. Oh, wait, you guys were, okay, and then everybody switch guessers, and what question? You're a Libra.
We're gonna go for Guillain-Barré for 200.
All right, Guillain-Barré for 200. Okay, remember, raise them high. In what stage does the patient begin to recover? Okay, so up front.
Stage 2.
Stage 3. Yeah. So remember, stage 2 is the plateau where they kind of stay and then they go back. That's okay. That's okay.
All right.
What's that? Okay, switch your guessers. And then let's see, Tara, do you want to pick out one?
Potpourri for 500.
Woo, potpourri for 500. Get ready to raise them high. This is another name for trigeminal neuralgia. Tara,
Facial nerve?
it's incorrect. I'll give somebody else a chance to guess. Tracy? Tic de la Rue. Yeah. I think, am I saying, wait, where did? Yeah. Tic de la Rue. Okay. So that was here. And then you guys are 1, 2, 3, 4, 5. Thank you. Oh. It's okay. You're on the board. Okay. Julius, what are we choosing? Guillain-Barré for how many? 100. Okay, 100. Get ready to answer. Raise them high. Main symptom of this disease. What? What's the main symptom of this disease? Sorry, I can't hear you. It's ascending and descending paralysis. Yeah. All right, you guys were 4. Okay. You guys can go ahead and choose another one. Myasthenia gravis 300. You guys all switch your guessers? Okay. Raise them high. This is a hallmark symptom of myasthenia gravis. Yes, Melanie. Yes, very good, right? We know that they get fatigued, but it gets better after rest. Very good. You guys are 6. All right, which one are we going with now? All right, myasthenia gravis for 400. Did we switch our guessers? Yep, okay. Disorders of this gland are often associated with myasthenia gravis. I saw Jasmine Sanford. Yes, the thymus gland. Good job. Oh no. My bad. Points for everybody. Okay, so switch your guessers and then what one do you guys want to go with? MS for 200? All right, MS for 200. Women are this many times more likely to develop MS. Yeah, Kelly.
2 to 3 times more likely.
Yeah, 2 to 3 times more likely. Good job. And you guys are group 5. All right, switch your guessers and which one do you guys want to go with? Yeah. ALS for 300. Oh, that's already highlighted. Signs and symptoms are muscle weakness and
I don't know.
I saw Joyce and Amar or Amy, excuse me. What's that? Okay, go. It's muscle spasm or twitching. Yeah, yeah, yeah. You're getting there. Okay, group number 1. What's so switch your guessers and which question do you guys want? All right, potpourri for 400. This disorder is characterized by feelings of pins and needles in the legs. Kathy.
Restless leg syndrome.
Yes, very good. All right, switch your guessers and then which question are we going with? ALS for 400. Name a common complication. Yes.
Muscle spasm and twitching.
I'm gonna say pain is muscle spasms. All right, well, we could talk, you could talk your way into it.
We need it. We need
You're back to 0. Okay, go ahead. Switch guessers. And which one are we going with?
How about the one you're on?
Guillain-Barré for 300. What's the highest priority complication? Kelly. Yeah, respiratory failure, right? There's a lot of issues, but that's the biggest one we're going to be concerned with. You guys are 4 or 5? 4. 5. Okay, switch your guessers. And what question are we going with now?
Guillain-Barré for 400.
Ooh, high ticket item. Okay. May be required if the patient cannot breathe on their own. Melanie. Yeah, they might need mechanical ventilation. Nice job. 6. Okay, switch your guessers and then which one are we going to go to now? ALS for 500. This medication's given to decrease saliva production. Kathy. I would like a specific one, Julius. Yes, yes, yeah. So it helps that, but I was looking for more specific medication. So I won't count you negative, but nice job. Okay, switch your guesser and then which question we go with now?
MS 100.
MS for 500? 400. Oh, here we are. Thank you. Okay. MS is typically diagnosed between these ages. Oh, Rachel. 20 to 50. Do you just have your book open right there? It's oh okay. We should all look at Kelly's notes because she does have this really cool notebook that organizes her notes in a very beautiful fashion. So it is very nice and very helpful for Jeopardy. Okay, switch guessers and
So my seniors gratis for 500.
okay, guys, get your guessing hand ready. This class of medication is used to treat myasthenia gravis. Kelly?
Anticholinesterase.
And yep, so anticholinesterase like neostigmine or prostigmine. Oh, okay, switch guessers and which one we go with now?
Potpourri 200.
This disorder is characterized by intense pain on one side of the face. I saw over here, yes.
Trigeminal.
Yes, yeah, trigeminal neuralgia. Nice job. Hey, you guys are back positive.
That's a win right there.
Okay, and which question are we going with?
Jan Bar 500.
Oh, okay, last 500 question.
Yes,
Guillain
we
Barre.
gotta get up there.
Stage 1 can last this long.
Wait,
Wait, okay,
it's
hold
20
on.
It's 20.
In the very back.
I thought we were upper.
Yeah, but you didn't have the answer.
Yes, we did. I thought I said 20.
I thought you were going
No, I said 20. That's right. Just give it to him. Let's just give it to him.
Oh. Okay, this is
Oh my God.
too much pressure here.
You can have it.
Everybody gets 500 points. I don't know. Actually, yeah, why don't we just give everybody 500 so we're all on the board? We're all gonna know.
Yes. It's okay. Team 5 cooked all of us.
Okay, which one we go with now?
We do ALS 100.
ALS 100. This disease is also called this famous name. I did see Bria.
Garrick's disease.
Lou Gehrig's disease. Good job.
We should start it.
All right, which one are you going with next?
We're gonna do MS for 100.
Okay, MS for 100. MS is a chronic progressive degenerative disease that affects this. I think that's what it's like. The myelin sheath. Nice job. Woohoo! All right. Myasthenia gravis or potpourri?
MG 100.
Okay. MG is a chronic disease of this. Rachel?
Voluntary and skeletal muscles.
It's the neuromuscular junction. Sorry. You shouldn't raise your hand if you
Now you're
don't know
only
it. Okay, potpourri is the last one for 100 points.
Let's go.
Post-polio syndrome affects patients this long. I saw Kathy's first. 10 to 40 years. Yeah. Okay, everybody give yourselves a hand. Nice job.
Team 5 ate that. Oh,
Dang.
How about let's take just a quick break and then we'll come back and do a medication activity. So let's come back at 11:25. And yes, you're still gonna be in groups when you come back. So please come back to your groups.
Yeah, it's right there.
Yeah, she came. Yeah.
Pues es.
So the sheets that we've been doing, I don't know if people have been mine yet, but I wrote mine. And is that okay? Okay. I don't prefer writing for like reading. I prefer reading. Okay. Yeah. The typing, I was like,
I think
oh
it-
my goodness.
No, I think it will really.
Okay. Same thing. What was that next week? I did a- It was too much, I think, for me, it was one output, just one day, days, but then following. I got my Two cents and class. It's like, oh my goodness, that's crazy. Yeah.
Oh, no, I'd be like, no, you're gonna change that.
It's like I have, I do it to 12, and I do it to 8, and I have class first, like, that's all.